So welcome to today's symposium, Getting It Right First Time in Severe Aortic Stenosis, Key Insights for Long-Term Success. I am Ole de Bakker from Rikshospitalet Copenhagen, and it is with pleasure to be joined today by Darren Mylott from Galway University Hospital in Ireland. So we will also be joined by Dr. Colm Owens and Dr. Mark Spence live from Royal Victoria Hospital in Belfast, also in Ireland in a while. So during today's session, our intention is to cover the following educational objectives. First of all, to discuss new and important aspects when performing TAVI in younger patients. Also, secondly, consider determining factors for choosing valves in these younger and lower risk patients. And finally, also to recall current and predicted trends in TAVI with respect to preserving coronary access. So this symposium will begin with a short overview by Darren and myself, and then we will join Colm and Mark from Belfast, where they will perform a commissural alignment TAVI live case. So let's bring up the slides. So Darren, maybe you can take a kickoff on this session.
So thanks, Ole. Let's have an enjoyable session today. So I think when we consider getting it right the first time, it takes me back to when we initially started performing TAVI nearly 2 decades ago. And really at that point, TAVI was all about, getting the patient off the table successfully without having a catastrophic complication. So procedural safety was crucial. We were concerned with procedural mortality. We were concerned with stroke, major vascular complications in particular. And of course, then the issues of paravalvular leak and permanent pacemaker came to the fore. More recently, as we've been, I suppose, getting better procedural safety, we've been able to focus then on the longer term issues that are important for patients, ensuring that we have good access to their coronary arteries so that they have, if they present with non-STEMI or angina, that we can deal with that percutaneously. We want to make sure that we get good hemodynamics at the end of our case to ensure good valve durability, because we do believe that those post-procedural hemodynamics are inextricably linked to the durability of the transcatheter heart valves. And then perhaps the final step along that pathway is being able to revalve the TAVI, redo TAVI or TAV and TAV, so that if patients live long enough to develop structural valve deterioration, that we have an option to treat them percutaneously without having to explant the valve, because we know that that carries considerable risks. Ole, take us through procedural safety with the ACURATE Neo valve. What's the experience been with that?
Yes, I mean, it's true what you say. I mean, in the early days of TAVI, it was all about procedural safety, and just even to let your patient get successfully coming out of your procedure. And nowadays, you see in current practice, what we expect from our TAVI devices or TAVI procedures is extreme low mortality. So you see intraprocedural death or mortality rates, which should be below 0.5%, I would say. And of course, that's depending on the spectrum of complexity of patients you treat, but that's what we expect. We expect almost no annular rupture. We don't expect any coronary obstruction anymore, as low as possible, close to zero procedural mortality. Also major vascular complication rates with these lower introducer sheets, French sizes up to 14 French. We see major vascular complication rates in clinical practice up to 2–3%. Also, acute renal failure is almost non-existing, I would say, in my practice. So Darren, also then if you were talking about PVL, so what do you think are important aspects there to emphasize?
Well, I think we all know of the association with moderate or greater PVL with longer term mortality that was really shown with first generation devices. And so most devices have iterated to try and reduce the incidence of PVL. The ACURATE Neo 2 valve is no stranger to that. And really the change that they've made by lifting up that outer skirt and making it, I suppose, more flexible. You can see in the image on the screen the way that the outer skirt can fill up essentially during diastole and produce a really good seal around the annulus. And not surprisingly, therefore, when we consider this particular prosthesis where we saw higher than expected and higher than acceptable rates of paravalvular leak with the ACURATE neo1 valve in scope 1 and scope 2, we have seen in this large registry a significant reduction in paravalvular leak, both measured with video densitometry and with core lab echocardiography, to paravalvular leak rates of 2.7, 2.5%, which one would consider acceptable in 2022. So a big step forward, and I think that's really important in terms of patient outcomes. More the focus is going to be on reducing those mild paravalvular leaks, and again, perhaps more work for all of our TAVI prostheses to do to achieve that, but certainly encouraging signs. Ole, what about permanent pacemaker implantation? Because we have seen moves with other prostheses towards getting the valve a little bit higher to reduce the amount of metal in the LVOT to get those pacemaker rates down. How is the ACURATE neo2 valve performing? And is it necessary to get this valve very high during the index procedure? Because of course that can affect the possibility of revalving in due course.
A good question. I mean, I think nowadays what we want to see in doing TAVI is that we have a single-digit pacemaker rate in our population, and that's also what you see with an ACURATE in the latest early Neo2 registry. They have a pacemaker rate of 6%. I think they obtained this because, first of all, it's a softer valve. But there's no discussion with this particular valve. I mean, of course, it depends from valve to valve. There are some optimized implantation techniques which are applicable to some self-expandable valves. But I think with the ACURATE valves, you just aim for a nominal implantation depth, and that you obtain thanks to that upper crown, which holds itself just above the calcified leaflets. But that also prevents that you have very deep implants and that you have these high implantation rates. Also, the stent frame is straight. It has an acceptable radial force. So that's why these pacemaker rates are being kept in a single-digit range. So you were also mentioning, Darren, to move forward further, that preserving coronary access is important. Is there anything particular there that you want to emphasize? We're going to see a live case from Belfast in a couple of minutes. So any quick thought on this?
Well, I think this valve is as you can see, the frame of the valve, while we have these stabilization arches, the valve is wide open. And thus ensuring coronary access is very easy with this valve. As you can see from the image on the screen, the upper crowns are below the level of the coronary arteries and can even facilitate access into the coronaries. So this is a good prosthesis in your 40 to 50% of patients who have underlying coronary artery disease.
Yeah, and hopefully we'll see
hemodynamics, valve nice durability.
Yeah.
What information do we have on durability and valve hemodynamics?
Also there, I think you have to aim for a single-digit mean gradient after your TAVI. That's what I want to see in my patients, and that's also what you have in this particular valve and the ACURATE. I think it's thanks to this supraannular leaflet position, of course, that even in the smaller anatomies, that's typically the cases where you're a little bit afraid of the higher gradients, even the risk for patient prosthesis mismatch. I think there you really have the full benefit of this slightly higher leaflet position. And also on long-term durability, this gradient will probably have an effect. So then finally, last word on revalving possibilities, or maybe we can take this later if that's okay for you, Darren, because I think if that's okay, then because I think they are ready in Belfast, and I think we are ready to cut to Belfast and join Colm and Mark in the lab. Hello, Mark and Colm. Are you there?
Hi, Ole. Hi.
We are here. How are you doing?
Nice to hear from you guys.
Hi.
We've been listening in, and it's a nice moment. So we sort of are following your discussion there. So, I mean, are you happy? We'll just move into introducing the case. We're in Belfast. Colm's with me as first operator, so he's just working away, and we've got our team here. A few of our Boston people with us. So you've got some slides up, and I'll just move forward one, please. So we have an 81-year-old gentleman with us today on the table, under conscious sedation. He has typical severe aortic stenosis, gradient 75, mean of 42, valve area 0.8. He has a little bit of more things going on. He's some concomitant coronary disease, although this is asymptomatic. There was IFR done of modest LAD disease, which is 0.65. And he also has lung disease with pulmonary fibrosis, bronchiectasis, not such great lung function tests. And he actually, I was just being manifest today, he's osteoarthritis and is also on a waiting list for hip replacement, which he's finding a little bit uncomfortable on the table here. So he went through usual heart team discussions, and in a patient-centered way, he actually did go to see a surgeon, and the discussion was around coronary artery bypass grafting and SAVR versus TAVR and expectant management of the coronary disease, or deferred management of the coronary disease, which I think relates a little bit to our valve choice today. So in a patient-centered way, he had that discussion with our surgeon and ultimately opted for a TAVI type approach, with some discussion around valve choices and how the coronary disease could be handled if it needed to be handled in the future. So perhaps I've chatted a fair bit. Maybe that opens up a comment or two from you guys. And
so that's absolutely it. The patient actually probably is equipoise in terms of eyeball test, Darren, for surgery plus Lima versus TAVI, but the patient preferred TAVR, principally due to a number of reasons. He wanted a quick recovery, and he's really disabled with right hip pain. And so there is hip surgery planned for the imminent future. Next page, please. As ever, when these are still images, but you can see this is a trileaflet aortic valve, peak gradient 75. And I wasn't too concerned. I'll show you a still image of the LAD. The IFR of this was 0.65. And the question was PCI and TAVI, which I wouldn't personally entertain, versus TAVI only, which we're doing today, versus surgery and Lima. And he opted for TAVI only. Next page. So you can see the valve isn't very significantly calcified. Unfortunately, the CT was done in a peripheral hospital and the calcium score wasn't calculated, but it's a trileaflet valve with modest calcium. Next. And in terms of assessing it, the patient's 5'2", he's not that tall. This is a relatively modest annulus with a perimeter of 70, 69, an area of 374, and a perimeter-derived diameter to calculate the balloon that we're going to use to predilate this of 22. So we're taking a 20 nucleus. The left coronary is 12 millimeters high, but the sinus of Valsalva width at that depth is 35, so pretty capacious. But you can see on the top right-hand panel, he does have calcium in the left main. He does have coronary disease. So one of our questions in choosing the right patient and the right valve is, what valve are we going to use for relatively small anatomy, for reaccess into this coronary in case he should develop angina? At the moment, he's fairly limited by hip pain, but it's entirely conceivable we'll fix his valve, he'll get a hip, and then that coronary could come into play. Next slide, please. Access is okay. And for the deployment here, we've got an LAO2 called 11, which we've modified to an RAO to get a good 3-cusp overlap in our pictures. Our commissural alignment is this fairly steep right caudal, and that's the view we go into for commissural alignment, and his legs are okay. So last slide. So in summary, we've got somebody with symptomatic severe aortic stenosis who's a relatively small annulus. We're going to use a Safari small wire for our support wire. We're going to predilate with a 20 millimeter nucleus because the perimeter-derived diameter is 22. And we're going to use a small accurate Neo2, which is 23, and hopefully show you how to achieve commissural alignment with the principal role to ensure future coronary access for intervention. Now, Ole, I know that you have a number of slides that maybe is going to demonstrate how to do that.
Yeah, and I mean, I wonder if we showed you where we're at, we can then let you perhaps talk to that. So, Colm, maybe we'll show you our pictures of our 3 sinus view.
So we've got right femoral access, right radial access. We can whiz past all of that. We have a 14th eye sleeve in the right femoral. He's received a little bit of sedation. And just go to the last.
So usually our 3 minutes, it gives us good angles, but we were ever so slightly off. Just I think he's maybe repositioned himself. He's a bit uncomfortable on the table. But our 3 sinus view just
is an REO 10, caudal 11.
Is there. You can see the catheter in the non-coronary and the.
So I think this is important to demonstrate, because for optimal implantation of the accurate Neo2, really what you have to understand is the most basal insertion point of the non-coronary cusp. So your pigtail needs to be right down at the base of the non-coronary cusp, and we'll push it down before we implant it. And then understanding the relationship between the inflow part of the accurate Neo2, that 7 millimeter depth that we want to achieve in order to get maximum strength of the valve and of deployment. And it doesn't influence the pacemaker rate.
And I think you can see on our screen here, he's got a good going gradient across the valve of over 50 millimeters of mercury and nice narrow QRS sinus rhythm. So we're going to move on. We're going to position the Safari small wire column just crossed there. And perhaps, Ole, you could maybe talk to the specifics of the specifics of how to achieve commissural alignment.
Okay, thanks, Mark and Colm. I think indeed I will try to keep it very short, 2 minutes. We will now provide a short overview of how to obtain this commissural alignment with the accurate Neo2. So maybe can we have these slides up? There's some slides. There are some further slides, or a second slide deck, I think. Let's see. I think it's the following. Yeah. So in the accurate Neo, first of all, in order to implant your transcatheter heart valve with the commissures aligned with the native commissures, you have to know how these commissures are detectable on your transcatheter heart valve. You see on the accurate, it has posts, it has a free cell, and these are also visible when the valve is still in the catheter. So that's very important. You see these posts and you see the free cells just below the upper crown. So that's important that you know that. What do we use of fluoroscopic view? We are going to use the right-left cusp overlap view, as discussed and shown by Mark and Colm. So what does it mean, the right-left cusp overlap view? That means that you overlap the right and the left cusp on the right-hand side of your fluoroscopic screen. You isolate the non-coronary cusp on the left-hand side of the screen. That also means that the commissure between this right and left cusp is pointing to the right of your fluoroscopic screen, as you see in this illustration. And that's also where you want to have this transcatheter heart valve commissure being aligned with. How to do that? Well, very simple. You go to that right-left cusp overlap view and you rotate your valve until you see one of the posts and one of the free cells aligned on the right-hand side of your fluoroscopic view. There are some manipulations. I think we're going to see that live demonstrated by Mark and Colm. But there are some tips and tricks in the three-cusp coplanar view. Then you go to the right-left cusp overlap view to do your rotation, and then you go back to your three-cusp coplanar view to do your final implant. But I think it's more interesting to see this live. So let's go back and live to Belfast, and I think it's now time to dive into the commissural alignment case. So over to you, Colm and Mark again.
Thanks. So we're going to concentrate on commissural alignment, but we'd also like to talk through how to deploy a valve well. So one of the most important things, and I know, Darren, you alluded to this, in terms of prepping this valve for the accurate Neo2 is a decent predil. So the annular dimension here is 22 by CT. So we've chosen to take a 20 nucleus, and we're about to predilate now. Okay, guys, can we get on to coupling?
So we've got our temporary pacing wire formally, we're not pacing on wire. We've got a dedicated temporary wire inserted here.
And get some phenol ready, just blood pressure stepped a little bit. Okay, get
and Mark,
ready to
is that your typical practice?
Yeah, we have stayed with that, to be honest. We've played around a little bit with pacing on wire, but we've just stayed with that. We think
180 on.
The very occasional time when you lose pacing on your Safari wire, it can be messy, but
180
you end
off.
up having a little bit of a mini crisis, even though it's not that often. So we've just stuck with that approach. So.
Okay.
So this pre-dilatation is very important when doing an accurate implantation, correct? Or what's your opinion on this?
Yes.
Yeah, I mean, I think that's certainly the narrative from the community is that it's important. Preparation is very important for this valve. We always take care to do that and I don't think the shortcut of avoiding that is worth it. So yeah, we always pre-dil.
Okay, so Ole, we've done a pre-drill here now, so we're pretty much set up for deploying the valve. A couple of things we want to focus on. The valve travels very well through the body, so in small access, this is a nice valve to use. We're going to concentrate on keeping the flush port down when we're introducing it, because that maximizes the chance of commissural alignment. And then Mark's role as operator 2 is really to control the wire in the left ventricular cavity. We've chosen a Safari small wire because it maximizes the chance of the delivery system to be on the outer curve of the aorta, which is very important to get an optimal deployment. The valve's interesting. It deploys from the non-coronary cusp across to the left, and we really want to have this valve in the non-coronary cusp with the delivery system on the outer curve of the aorta.
So I think you can see perhaps just on the screen here, this flushing port, which you can clearly see these sort of techniques have been developed after the device was locked down for manufacture, and that it points directly into the bed.
So advancing.
Which I guess you watch doesn't snag in the patient's toes on the way past.
So it's delivering well through the eye sleeve. There's no
Just let me catch up, column slightly.
We don't tend to screen down at this stage because it goes well. We're concentrating on keeping the flush port down at 6 o'clock. There you can see that's gone through very nicely. We bring this little introducer back and dock it, and then we'll go into LEO 30, please. So what we're going to demonstrate
to which view do you go now? Tell us exactly to which view.
Yeah.
Is this now the tricuspid view, or?
So just across the arch, Ole, I typically go into an LEO 30 just to watch it go through the arch. And then when I cross the valve, we cross it in the 3 cusp alignment view. That's our starting and our ending view to deploy this valve. The commissural alignment, we go into the 2 cusp view just to get that piece sorted out. But our start and our end piece is the 3 cusp alignment. I just like going into an LEO 30 just to appreciate this crossing the arch. So lights down just a little bit.
And I think it's fair to say this valve, I don't know what Darren and Ole's experience is, but I think we find this a very nice valve for navigating this portion of the procedure. It's very sympathetic to rounding the arch.
Just go to high fluoro for a little second as so we're going to negotiate the arch. The flush port is down. We're happy. The pigtail's in the right position, and you can see it delivers really nicely. Okay. So
yeah,
now
it's
we'll
very
go
flexible,
into the,
isn't it? I mean, in patients who have challenging aortas or calcium that you're worried about, it really is a very soft system coming around the arch. It is a big advantage. Also, in horizontal anatomy, you can manipulate the wire and the device, which you can't with other stiffer capsules.
So you can start seeing here the components of the accurate Neo2. You've got the nose cone, the stent holder, you've got the nice tantalum marker, and just up top, you can see the commissural post, which we'll be concentrating on. The wire, go ahead, Mark, I think,
Yeah. So I think it's the, I mean, Ole, you've mentioned the signature really on the valve, these fluoroscopic elements that allow us then to work out in 3 dimensions where we are. So relatively simply using the fluoroscopic landmarks. So I think you can see column is crossed through the annulus with a little bit of ectopy, or wires a little bit irritating. I think it's maybe perhaps a little bit irritant around
go to 22, please.
The mitral. I think we can, very interesting already. So we're in this 3 cusp view, and I think, I don't know if it's transmitting well to you, but you can see the 2 wings and then our 3 posts. So Ole will defer to you. I don't know what, in this scenario, we could be perfect or complete 180 degrees imperfect, I suspect.
So basically we can have a situation where the 2 posts can be on the outside, which means we have to clockwise rotate. The 2 posts could be on the inside, which means we have to counterclockwise. And here we're either perfectly right or perfectly wrong. So we're going to go into the 2 cusp alignment now. It's a little bit hypotensive, so we're going to crack on here. 2 cusp, please.
A lot of state depression, isn't there?
Speaks to the importance of maintaining that coronary access in due course.
So you can see now that we have to rotate quite a lot now to get this free post, which is on the left-hand side of the screen, round in. So I'm going to just anti-clock. You can clockwise or anti-clock. And it's important just to do this nice and slowly.
So one of the things I think it's important to say is that we certainly learned in the early phase sort of who does this, and I think it's very key that the operator one is one of the keys. He can feel what's going on his left hand and his right hand. So
there we go.
Winding up that.
So
torque is done by the first operator, and I'm really just very passive here.
Yeah.
No, the wire needs to go
really.
forward. So we're just going to adjust
you
the wire
isolated one of the posts and of the free cells on the right-hand side of the screen, so that looks good. Yep.
So I think if we just take a picture now, we have the wing almost pointing out to the left. We'll just maybe let it relax. I think we just have to come a bit more, Ole, around. What do you think?
Yeah, I mean, of course, you also don't want to compromise the safety of the procedure. So indeed, you torque, but I do it to a certain extent. What you want to avoid is commissural misalignment. It's not that you want to obtain absolute perfect commissural alignment. That's not always needed.
I would be happy with that.
Yeah, we're ready, Colin.
Yeah, this looks good. Yeah.
Yeah. So we're going to pull the wire back a little bit. Let's go into the two-cusp alignment. Now, very importantly, I've taken all of the tension out. The patient is stable. That didn't take much manipulation. And I think we have maximized our chances of commissural alignment. Our product team are just talking. What do you? Yeah. So they're just a little unhappy with our wire position. So we're just
causing a lot of activity, Colin.
There, that's better. So now we're going to advance. Now, the most important thing now is the interaction between the tantalum marker and the non-coronary cusp. So you want the pigtail right down, and you want this marker right on to the non-coronary cusp.
So you can see the optimal, this valve's nicely in the outer curve column, and that's clearly what we want. The valve will open from the non-coronary side, then across towards the left and right.
Okay.
And obviously a quick look towards those, towards the upper crown to make sure that that's looking like it's above the level of the calcium on the leaflets.
So coupling on, please. And we very clearly have to go in.
Good. So column is, you know, I think this, the most important thing here is to make sure that we have the lower part of the marker on that line through the annular plane.
So the next two phases of release, as Darren, you said, is the first phase of the release is to make sure that the upper crowns interact with the valve. So I'm going to do a coupling on and see where this is, but I think that's pretty close, guys. Coupling on. I'd be pretty happy with that.
Yeah.
I think that's bang on.
Yeah, lovely.
So we have demonstrated also that you can see there's enough stent frame below the annulus. You don't want, like other self-expanding valves, for this to go too high. My last movement is neutral and everything is stable here. So we're going to start release.
Okay.
So this is phase 1A.
So we're going live. So 1A is just so we have, this is still not fully committed at this point.
And we're going to just assess the interaction of the upper crowns with the valve.
So we can see column, the leaflets there, just nice and steady.
So we're going to release the stabilization arches now. And just want one last picture to see how we are.
Perhaps forward a nudge, yeah.
So I'm just going to put it forward a nudge. What do you think, guys? I think it's okay. There.
Good.
And now we're going to release.
Do you want to just leave her?
And there we go. And that's the valve released.
So the next thing we're wanting to see is that the stent holder is released, and we can see it has moved south.
So very importantly, we can now see that there's no interaction between the stent holder. I'm going to ask Mark to pull back on the wire, and then we are just going to gently take this stent holder back.
Looking nice, Colin.
And it looks really good, guys. Just taking our time. Go to 27 now, please.
Yeah, so very important to do this slowly as you are, guys. Given the you know, the fact that you can
and 48,
you can catch the frame of the stent.
That's right.
If it's not completely open. So a really nice demonstration to the audience that taking your time while moving the stent holder back through the device is important.
So now we're just reversing what we did. Mark is
Watch the wire.
Well, I'm just watching the wire. Mark
So
is
2 then 1. So we're redocking, and we'll use our big field of view here just to watch this coming into the eye sleeve, maintaining the wire in the ventricle, making sure we don't have any interaction with the inflow to the eye sleeve.
I quite, with all expanding sheath technology, watch the interaction of it coming out. Just hand down on your, that's good. Can somebody just speak to him and tell him his valve is in? And we'll take a pigtail. So we're not going to leave the wire in the LV cavity now. We're going to cross with a pigtail, take some hemodynamics, and see where we are. So to summarize what we've done so far, we've demonstrated how easy this valve is crossing an arch. This arch is quite long and unfolded. We've demonstrated how to manipulate the valve to get commissural alignment. We just really want to maximize the chances that there's not going to be a commissural post across the origin of the coronary arteries. And then thereafter, the optimal position, which is the tantalum marker in the non-coronary cusp, in that 3 cusp alignment.
And I think even with the wire across, we're seeing diastolic pressures around 50 or so here in between these ectopic beats. So it'll be nice to see what we get once we get this wire out.
Just go to 37, please.
Colin, tell us, how do you assess commissural alignment, whether you've been successful with this maneuver or unsuccessful? Will you take us through that once you have the pigtail in?
I'll let Mark grasp that in just 1 wee second.
Yeah, well, we can assess that whenever we go into if we can. The nice thing is the signature of the commissural post, so we can see the anterior and posterior positions, and we know that that's where the leaflets are inserted into. So we've got the signature. So then if we look in our 2 sinus view and we see those separated anterior and posterior, we know that we should be free to enter into the coronary. So we'll look at that in the 3 cusp view, then we'll go into our 2 cusp view. And if we have time, we can even bring a catheter up and intubate the coronary just to prove it further for you. We've got the pigtail in the ventricle.
Are you going to take out the jailed pigtail or not?
Yeah, we just observe. We'll take that out now so we don't bring the valve with us. So.
Yeah.
So we left I mean, I think usually it's fine. They're quite commodious sinuses here.
1 second. Just second pressure head, guys, please.
Colin will just bring that up free from behind the frame now.
Okay, sorry.
Yes, I also think it's totally safe to leave this pigtail in place during your full deployment. I've done it in all my cases too, and it's only important when you retract this jailed pigtail, indeed, that you use a J-wide as you're demonstrating nicely now. Indeed.
Yeah. So the hemodynamics here are excellent. We've got a diastolic now approaching 50, a really crisp notule, I think you'll agree, and no gradient across a seriously stenosed valve. So we're going to get the pigtail. What do you want me to do? Sorry.
So just to take the jailed pigtail back.
We're going to just take this jailed pigtail back.
So Colin's just putting the J up here, and we'll take that back, and then we'll be able to do an aortogram just to assess for regurgitation. We were pretty confident in our hemodynamics.
And then we'll assess for commissural alignment.
And then we'll give you a commissural alignment picture.
So
we're in our 3. What view are we in here at the moment? We're just to move into our 3 cusp view for us. So in our 3 cusp view, we can see it looks, we can see our 3 commissural posts separated equidistant. And then if we go into our 2 cusp view, which is quite an extreme REO caudal. So just give us a little blip on that column.
So having the 3 cusps equidistant in the 3 cusp view after manipulation that you've done should mean you're perfect.
So we know we're great here. We can see anterior, posterior, and we can see. I think we've done well. So
I think what we've demonstrated here is just that 1 minute, 1.5 minutes of gentle weak to counterclockwise rotation to get that those posts commissurally aligned has ended us up with a really good position in both the 3 and the 2 cusp. We're going to take a little picture here now.
Yeah. And then
but the hemodynamics are great, and I'm not really sure we need to do an awful lot more. We might try to demonstrate you the ability to get into the left coronary artery. So, Nicole, can you aspirate back? What's that? Yeah. No, we're going to do it in the 3 cusp. Yeah. Yeah, just aspirate. We've got one more shot left, yeah?
Yeah, guys, it's going to be very interesting to see where the coronary is relative to the upper crowns of this device. Obviously, in younger patients, that's going to be important for the possibility of revalving, perhaps not in an 81-year-old, but interesting to see nonetheless.
And we know that there's been some benchmark work done with revalving, say this valve in several years, 10 years, 12, 15 years, and he does last that long. Causes a problem. There's a sapien option for this. So we'll just take a picture, 27, just 3 cusp view, please.
I mean, we've left the pigtail in the ventricle here. There's always a small chance of some interference, but...
Will we take that out? Huh?
It's maybe a good idea to keep it because it's if you have to.
We'll just keep it there. I mean,
it's always some.
I think just in case of a post-ill, we'll just leave it there. Yeah.
I mean,
the classic teaching from Boston is to leave it just for the audience, so that you don't pick up any cells inadvertently in a recross. So we know that that pigtail's the wire's been there since before the valve went in. Yeah. But look, I think that's beautiful in terms of...
my inclination to pull it out was right because, you know, this looks great. So I think what we've got here, guys, is a very nicely aligned valve, good hemodynamics, no impact on the conduction system, no leak, and good diastolic performance.
So Colum's just going to use, again, a J-wire so the pigtail doesn't snag in the inflow portion to the valve. I guess there's always a small belly, And we've actually got a Judkins catheter here, so I guess we'll risk...
Let's see if we can put our money where our mouth is by trying to reaccess this coronary. Now, I'm a structural man, Darren. You know, my coronary experience is not as good as...
We'll invite Dr. Milet up to do the...
You should come up and show us how to do this, Darren.
Thanks, guys. I appreciate that. I think you'll be able to manage somehow.
Now, in real truth, coronary reaccess can be an issue. You know, I mean, I think we've all been there when we are struggling with trying to get into coronaries, particularly in, you know, the acute and chronic setting. So it'll just be interesting. LEO 30, please, just for me. Mark intubates in an AP, but I've never quite got there.
I'm old.
Mark, there is one important thing to mention with this particular patient is that with the coronary height of 12, pretty much all valves available on the market are going to come across that coronary artery. And of course, you might be lucky and be able to get through very easily, but with guaranteed commissural alignment, I think that's very important for this particular patient. And so while this particular patient could be treated with any of the valves, I think so. And I think the ability to ensure commissural alignment, really, there's only one valve on the market that does that, and it's the accurate Neo. So for this particular patient, I think it was a good valve choice. Notwithstanding the fact that the other elements to the anatomy could probably be treated by most valves on the market.
Yeah, I think that's a really nice point, that ensuring the other, you know, you're playing the percentages certainly with some of the competitor valves, and then the other, and certainly with sapien, you know, we don't really know we've no real method at the moment to ensure this. So I do think just using the signature of the valve itself and an understanding of the 3D space, quite a simple set of rules really can give you, as you say, using that phrase, ensuring commissural alignment with a high degree of predictability is really quite a nice way of describing it.
Sorry, that was a JL35, which is just our radial practice, but I think a JL4 from the legs has a slightly better catheter, so we'll just try that. But you can see, I think, Darren, you can see we popped down.
We'll just play you that, because you see, this patient had nice commodious sinuses. I think, you know, there's a safe environment there for a second valve and for coronary intervention. So I do think, you know, we're demonstrating the utility and the logic of this decision. And indeed, you know, because this patient theoretically could have gone down you know, there was a discussion with the surgeon, and this patient-centered discussion, the patient was involved in this discussion, and it's nice to be able to prove that our conjecture has been able to carry it out and execute.
Did you hold the wire?
But also the fact that, I mean, what do you need there? What do you think you need absolutely in order to obtain commissural alignment with a transcatheter heart valve? Of course, we discussed, I think indeed it's important that you see repairs, fluoroscopic repair points on that valve, even when it's in the valve, because if it's not, you do not know how to rotate this valve, and it also has to be torqueable in a way. Or what's your take on this, and where do you think this is evolving to in the future?
Yeah, as we mentioned at the start, Ole, I think that when we started this discussion regarding the things that you wanted from your TAVI, I think commissural alignment was way down the list.
Call, please.
But I think more recently we understand that this is going to become a really key factor in the decision to choose a particular valve for your patients, because of course there are many physicians who aren't involved in TAVI who don't know or aren't very au fait with getting out the struts of other prostheses. Of course, that's an education component, but I think with this device and future devices, they're going to have markers that you're able to identify the commissure posts, that you're able to manipulate those commissure posts into position. As you can see behind you on the screen that the guys have managed to get this JL4 catheter in quite nicely. And also the other thing that's important is that the commissure post itself is visible and relatively small. So even if you do get some degree of commissural alignment or misalignment, that it's really not getting in the way. So I think the guys have demonstrated quite beautifully here that with they promised the patient that PCI would be an option should they require it down the line. And I think with this prosthesis, it guarantees that particular statement.
Yeah, I mean that for even in expert hands like myself, that was a reasonably easy manipulation to get a JL4, and I think you could get a JL4 guide in here, no problem. That LED is not insignificant, actually, and I suspect that after he gets his hip done, he may be visiting us back again, and it gives me good confidence that we'll be able to deliver an interventional strategy.
But I think certainly the ability to have a fluoroscopic signature that and a relative easy ability to manipulate in the close to implantation position seems to be elements that are important, and we can see that in action today. So, yeah.
So
okay.
So
right now, what we're going to do is just get the legs sorted out.
We mentioned at the start.
Mark and Colmar, I want to thank you. I mean, it was a beautiful demonstration, really, of how to do an TAVI implantation with commissural alignment using this accurate Neo 2 platform. It was really a beautiful demonstration with a great outcome. You obtained commissural alignment. You have no PVL, no pacemaker. All these things we named up front as important. So your patient, first of all, he survived your procedure clearly. There's no PVL, no pacemaker. You have commissural alignment, so coronary access. So all what you want, you obtain. So congratulations for that. I think we're gonna move for 1 or 2 more minutes back to the studio, and then we're gonna finish. But congratulations with the case.
Well, look, thank you very much for your helpful commentary, guys, and all the very best.
Bye.
Thanks a lot.
Well done, guys.
Thank you. So Darren, I think we have 1 more minute left for this. What do you have as a finalizing remark on this after seeing this nice live case?
Yeah, so look, I think we saw a very nice case in expert hands. That's very clear. But I think if we consider the elements that we spoke about at the start, safe procedure, no complications, no pacemaker, no PVL, and then getting forward towards the more important elements as the patient ages, we've clearly seen we have good coronary access, we've got single-digit hemodynamics, and we have the possibility to revalve this in due course if required. I think that our decision in terms of valve choice is quite nuanced at the moment. It's probably going to become more nuanced as we understand more and more the durability of particular valves. But certainly this procedure should give us great hope that we're able to deliver really good outcomes, not just for these older patients that we have been treating, but more importantly for younger patients as we move forward into that age bracket.
Okay, great. Thanks, Darren. I think this brings us to the end of today's symposium. So this webinar was supported by an unrestricted educational grant by Boston Scientific. I hope that you found it informative and to have met its educational objectives. I would also like to, again, thank our faculty, Darren, also Mark and Colm, who did a great live case demonstration, I have to say. And our thanks for joining us today, and goodbye.